Hi, everybody. Welcome to our public education event, Clozapine, Why Aren't We Using This Schizophrenia Treatment? My name is Barbara Espinoza, and I'm NAMI-NYC City's Manager of Education and Outreach. As you may already know, NAMI-NYC has been helping individuals and their families affected by mental illness for over 40 years. We offer free mental health classes, support and social groups, family mentoring, and much more. If you have any mental health questions or would like to learn more about our programs, I strongly encourage you to call our helpline. You can visit www.naminyc.org, and we'll be sharing that information in the chat. Tonight, we're thrilled to have guest speaker, Dr. Robert Laitman, who specializes in the use of clozapine for individuals with schizophrenia. When his son was diagnosed with schizophrenia in 2006, Dr. Laitman became an expert on this treatment. Para personas que hablan español, Por favor de hacer clic en el globo en la parte inferior de la pantalla y selecciona español para oír la interpretación vivo en español. Si necesitan ayuda, por favor piden ayuda en el chat. También es necesario tocar donde dice silenciar audio original para solo escuchar al intérprete. We'll have a little bit of time for questions at the end, so feel free to share your thoughts in the chat. If you're having any technical difficulties, let us know in the chat and we'll address it as best as we can. Thank you again for joining us. And now I'd like to hand it over to Dr. Laitman.
Okay, let me share my screen. You unshared. Okay. Let's get that and share. And then I have to put it in the right slide set. Slideshow. And we're off to the races, guys. Okay. Welcome. This is really about what I strongly believe, which is truly the optimal treatment, not the good enough treatment of a broad spectrum of psychotic disorders. And it's not only clozapine, it is a very near and dear to the heart of NAMI, but it's engagement and community. And I just want to thank NAMI Metro for giving me this opportunity. This topic, it starts with Daniel. And it starts with my family. It's quite personal. And I want to use Daniel's story, basically, because that's why I'm here. I was a nephrologist and a gerontologist before this. But with what happened, I basically had to change career course. Otherwise, I wasn't going to be able to take care of Daniel the way I thought he deserved to be taken care of. So it begins really back in our history. My grandfather had schizophrenia. My uncle had schizophrenia. My aunt had bipolar disorder. Again, I'm giving you this information because Daniel, I want you to know it was very personal, but it's illustrative of what often is the history with a lot of people that have had psychotic disorders. So with Anne's pregnancy with Daniel, my wife, he was the only one subjected to gestational diabetes. All the other pregnancies were without complications. From the get-go, something seemed not quite right. He was a pleasant boy, a round, roly-poly guy, but he just wasn't like his sister, who was walking and talking before she was 1. He would roll around on the ground and not say a thing, and really didn't start walking until he was about 1.5. Was born fairly late in the year, October. We tried to put him in kindergarten. He ended up repeating kindergarten, which was one of our best decisions. He just wasn't ready. We were told of immaturity. But it was interesting because once he started talking, he never stopped. And he developed incredible vocabulary. But he was very clumsy and he was very different. My older daughter was already a talented soccer player. Daniel was not an athlete at all. And so we decided to get him psychological testing just to see what was up. And so at around 8, we got a full battery of tests, and we were right. He was a very smart boy. He tested out at the top 1% in vocabulary, certain cognitive skills, but he tested out at the bottom 1% in processing speed. And we were still told of immaturity and decided that he would struggle a little bit with since he was struggling a bit with social interaction, he started seeing psychologists. This went on for a number of years. Not much happened. Eventually, psychologist said, doesn't seem to be able to focus well on things. Why don't we send him to a psychiatrist? A psychiatrist prescribed ADHD meds, thought maybe he's a little depressed, put him on a antidepressant, bupropion. And time went on. It seemed to improve things for a short time. Came into high school. At this point, we had an individual education plan, an IEP. But he was doing well because he was smart. So he, did well in his grades. And if he was given a little bit more time and ability to focus, he seemed to do just fine. And then after freshman year, he did what he loves, which is go to summer camp. That's where he learned how to do stand-up comedy. And he had great experience there, but this is after freshman year at the age of 15, actually 14 going on 15. And it was different that year. He just looked tired when we'd visit him, but apparently what was happening was he was starting to hear voices. He was starting to see vapor trails. He was getting command voices telling him to hold his arm up against his chest. It got to the point where the voices told him something terrible would happen if he put his head down on a pillow. He didn't tell us any of this. We took him out of camp at the end of his session, went to Canada for our family vacation, but something was really amiss. He was walking faster than us, ahead of us. He would repeat his steps. He just was not acting right and seemed very preoccupied. People were noticing it. We would see people watching him. Well, we got back. He didn't tell us a thing. And we started them back on his attention deficit disorder meds, stimulant, and also on his bupropion. Within 2 days, the light had gone completely out of his eyes. He looked like he lost his soul. So at that point, we rushed him to a psychiatrist. Figured, okay, took my head out of the sand. I knew my genetics. I kind of knew something was up. I was, not thinking psychosis and schizophrenia, even though I had a strong family history. But again, I was busy doing my medical practice. But now I was thinking schizophrenia. And started him on an antipsychotic. Just made him stiff. Didn't do anything for the voices, command hallucinations. Started them on another, and then another. Over the next 6 months, Daniel was subjected to 4 different antipsychotics, 3 at the same time. We started to think that there was something really wrong here, that this wasn't really the way to go. So we started to read. And I got very fortunate because I met a woman by the name of Deborah Levy, who was the head of Harvard's McLean Psychology Research Lab. And that was pure serendipity. And she said, after she heard our story and met Daniel and tested him, said it's quite psychotic. He needs clozapine. This is about 6 months in the illness. So I thought, okay, he needs clozapine. You said it. She took us to her, the head psychiatrist over at Harvard, a guy by the name of Michael Mufson. Needs clozapine. You should start it. I'll talk to your treating psychiatrist in New York. It wasn't to be so easy. So the head psychiatrist said, well, let me try some other things first. Well, this went on for another year. Again, doctors aren't supposed to treat your own. That's what we're always told. So I was trying to be patient. My wife was insistent initially that I shouldn't treat Daniel because he's my son. And we waited and things got worse and worse. He became a little suicidal. Just more ideation, never an active plan, but it was definitely there, and we definitely hid the knives. Became, to all intents and purposes, a lot of transgender. Nothing wrong being transgender, but Daniel never had expressed any of that before. So he was shaving his legs, wearing a wig. So it got to the point where we even went to a transgender psychologist in the city. We explained to her everything about Daniel, how he's hearing voices, how he's clearly psychotic, how, he's, there's multiple delusions and he's clinically not well. Well, then she met Daniel and she told us we have a transgender son. Fortunately, she went on vacation in early March of 2018. And at that point, I said, it's time to start clozapine. We started them on clozapine. It was rough in the beginning, which is not unusual with clozapine. In fact, Daniel had an aspiration pneumonia. I hadn't read about the side effects, only read about how effective clozapine could be. We got him through that. And after about 5-6 months, he started to become remarkably better. And as time has gone on, he went to junior college, after graduating from high school, which we were told initially never would. Was Phi Theta Kappa, which is the honorary society. Then he went to SUNY Purchase, where he started a stand-up comedy club and was on the dean's list and graduated in honors there. And I am happy to report, like most people with schizophrenia, he's living in New York City, fortunately not on the street, in an apartment, but living in New York City, and he's a stand-up comic and a very successful one. I refer you to Daniel Laitman, oh my God, comedy, I believe, .com. Just look up Daniel Laitman on YouTube to be sure. But we were convinced there was something wrong at this point. So let me go into now what we're treating now, because Daniel was just the beginning for us. We decided we needed to do more for people, and we decided we had to take care of other people with psychotic disorders. So let me explain to you who we take care of and what these disorders are. So first of all, they are very complex. They are very heterogeneous. It means there are very big differences between every individual. And they are complex in terms of their polygenetics. This is old slide. I just love the slide, so I keep it. But there's a more recent slide with over 300 of these little markers. This is what's called a Manhattan plot, and these are the little skyscrapers. The very high skyscraper is something that is responsible for almost 25% of the risk in the community. That's why it's so much higher than all the rest. And this is for complement, which is a part of your immune system, which would identify to your body something that needs to be removed. So what happens in a lot of individuals is this complement ends up on the cells, and unfortunately on dendrites and axons, parts of your neurons in your brain, and it leads to overpruning. A lot of these other little skyscrapers, as we see, pretty much uniformly have to do with synaptic formation, axons, dendrites, and also parts of neurons. These are all genes that have to do with neurodevelopment. So, what are the features of psychosis? Everyone always talks about the psychotic break. And that's really all about dopamine. Absolutely, it's about dopamine. It's about salience, being able to give importance to real phenomena. And that is the delusions, the hallucinations, disorganized speech, and at the worst case, absolutely catatonia, where you're so internally directed, you're entirely detached from reality. And that is mostly the dopaminergic system. But honestly, that's not what will get most of these kids to the point where they remain disabled. What is significant is these people have other components to their psychotic disorders that lead to the social occupational dysfunction, that lead to the lack of self-care, that lead to their detachment from society. And those are the negative and executive symptoms. You've seen it yourself, the flat effect, the one-word answers, the inability to get started. You can't enjoy anything. These kids, like Daniel, very frequently have very decreased processing speed. And it's a tremendous stressor for them to get into social situations because you need good processing speed to go and have a social interaction. So that leads to social withdrawal. Now, the brain needs stimulation. As they withdraw, they lose more and more connectivity. They lose more and more of their brain. Their attention, their memory goes. And with that, often there's very prominent mood symptoms. And ultimately, that can express itself in hostility, agitation, but worst case scenario, in suicidality. I put comorbid substance abuse because it is so common. 3/4 of all individuals, if you're going to count cigarettes and alcohol in there, will be using substances by the time they come to medical attention. Hope you remember the story of Daniel. Okay, so this is a slide where there's a lot of confusion because, you read the papers and you hear the person being diagnosed with ADHD, bipolar, schizoaffective schizophrenia. Well, They don't have all those diagnoses, and the diagnoses really are fairly trivial. It's basically, as I said, it's a spectrum of psychotic disorders, and all you're doing is catching these people at different parts. And again, so this slide's divided into neurobiology, the risk factors, and the course. As you can see, what's typical of most psychotic illnesses, the negative symptoms start first. But as the negative symptoms progress, that is a tremendous stress on the system. And often at that point, it'll be coupled with substance abuse. Often that's going to be the first diagnosis when they have a psychotic break, when they're typically smoking cannabis. Cannabis in and of itself is a 5-fold risk. By the way, so are the ADHD drugs. Then the psychotic episode gets better. Let's say they give up their cannabis, but they get another psychotic episode. What is it? Now they'll be typically told bipolar. Time marches on, they get treated with the good enough treatments, which is the D2 antagonist. Again, it's only going after that dopamine system. It's not going after the rest of the brain. The negative symptoms gallop along. The thought disorder gets worse. So now all of a sudden, there's a little bit less mood component. There's more of a thought disorder. They're just not making sense. They're withdrawing more. Now we call it schizoaffective. Time marches on. Now it's schizophrenia. And you see primarily the negative symptoms. And they become more and more detached and often more and more out of society altogether. So I don't want to talk about good enough treatment. I want to talk about something that addresses the whole spectrum of the illness, and that's clozapine. Now, clozapine has been around for a very long time, and it's been given a bad rap from the very beginning. It was synthesized by someone by the name of Schmutz. And for my Yiddish-speaking people in the audience, that means dirt. It got off to a bad start. So clozapine hit the market, was accepted immediately by families. They loved it. But psychiatrists didn't understand because we were taught, and I was taught this even early in my med school, you needed to block dopamine too. You'd almost make these people Parkinsonian before you knew you had enough receptor binding for them to handle their psychosis. And clozapine didn't affect motor appreciably. So they were perplexed, and it really never got off the ground in the 60s and the early 70s. It was being introduced in the United States. It was under study. And in 1975, in a small Finnish village, 16 women developed something called agranulocytosis, which is a very low white count. The white count with the neutrophils went down below 500. And what the problem is with that is it made them very susceptible to infection. And out of the 16 elderly women, 8 of them died. Clozapine came off the market. However, when it came off the market, compassionate use continued, and there was an outcry for it to come back, and it came back into Europe in the early 80s. And finally, in 1989, John Kane with Gil Honnensfeld and a very stringent protocol that was actually developed by the FDA, clozapine came back on the market. Basically, the study that brought it back on the market, clozapine could only be introduced to people, and this was the study, where they had failed 2 antipsychotics at high doses with documented compliance for greater than 6 weeks on both of the antipsychotics, and then subsequently were given 60 milligrams of Haldol and did not show a clinical response, again, for 6 weeks. So clozapine was compared to Thorazine, and at that point, and what they found is that Thorazine was not effective at all. Not a surprise. Less than 3% showed any clinical response, whereas in clozapine, well over 30% responded. So the clozapine came on the market. Did it? It hit the newspapers. It was on Time magazine, the cure of the year. But by that point, the patents were running out. So, and it was heavily restricted and rationed. It was tied into a cumbersome, which exists to this day, monitoring system, because when we first came on the market, we expected to have a real problem with the white count. In fact, Gil told me when he put this thing, Gil Honnensfeld, when he put it in place, we expected to see 3% of our patients dying from severe neutropenia. Well, this is what I was told, now, how many years later? 1990, this is 30 years later, 35 years or 33 years later. But we were told this in the very beginning. We were, again, the 3%, which is not the truth, and we'll go over that. We were told my son would be a fat slug, that it was a drug of last resort. He'd be drooling, intractable constipation. His heart would fail. It would kill him. It's a killer med. It's the drug of last resort. No one told us what was actually already in the literature at this point, that it was the only treatment that would work with resistant schizophrenia. The odds are when you fail one drug with good compliance for a therapeutic, with therapeutic levels for a 12-week period, you fail one drug, the odds that another drug besides clozapine is going to give you a meaningful clinical response is well less than 5%, except for olanzapine, which is 7%. Also, no one told us that it's the most effective medication in all settings, even outside of resistant schizophrenia, that it has the FDA indication for suicide, and Daniel was suicidal at the time. Violence was never an issue, but it often is. I hate to tell you this, but people that have poorly treated psychosis, especially in the setting of substance abuse, are not infrequently violent. In South Maudsley, London, there's an incidence of violence of over 20%. And usually it's directed against family. But more importantly, no one told us that it has the best acceptance, the best discontinuation rate. It will give him a chance of having a full, meaningful recovery. And as opposed to killing him, it's associated with the best survival. When is it almost never used? Well, that first year of psychosis. And this is why I'm going around and talking to first episode psychosis programs. The first year of illness is probably the most dangerous time of any of your kids' lives. The incidence of death, I would like to just put a number in there between, it's about 50-fold that of the general population. We see in the population over the lifetime risk, 50% try to complete a suicide, up to 5 to 10% complete it, and in the first year, as high as 3. 5% is a little high. I have to revise this slide. So if we were to treat with clozapine early on and continue this is over the lifetime of the individual. Given the studies that have been done comparing clozapine to other antipsychotics, the 380 would be compared to olanzapine. The 900 is compared to all the other antipsychotics. We would save 380 to 900 lives. Why don't we do it? Because we have clozophobia, the irrational fear of clozapine. What is the real risk of this severe neutropenia, the low white count? Well, this slide's also a little old, 0.3 to 0.8%. I'll show you some more information that it's actually lower than that. And the incidence of death is at the high end, 1 in 10,000. Almost all the risk occurs in the first 18 weeks. Actually, when you look at clozapine and you look at the risk, even though with the FDA right now, we have stringent monitoring with clozapine, you have to do weekly bloods for the first 26 weeks, every 2 weeks for the next 26 weeks, and then monthly bloods thereafter. But the funny thing is, when you compare the risk of clozapine-induced very low white counts, it's less than other antipsychotics. Iceland has stopped. Denmark has stopped. There are other countries that have stopped monitoring. China has also stopped, but, that's China. So we're missing an opportunity, and we're missing early. We also know that you treat early, it's easier to take care of most of these kids. All right, this is the best study that I was just referring to. This is out of New Zealand. David Taylor, it's 14 years, a lot of patients he personally was involved in. There was actually 16 events, but if you actually looked at the events, 7 weren't real. So there's only 9 events in 8 patients. So the incidence, 0.23%. Let me put this into context. That means 99.8%. I think you guys would go to Vegas with those odds. Do not have this happen to them. 6 of the 8 that had it had previous neutropenia. There were 0 deaths, which is what is the usual. And when did it happen? It happened from 21 to 105 days, and there were no events after that. What's really important, remember, it was the elderly women in Finland that got neutropenia. It turns out the median age of initiation of treatment was 51 years. There's only one kid that 25 that developed neutropenia. Everyone else was older. So what's its conclusions? And I agree with these. Most cases of AGRAN, again, the low white count, are not life-threatening. More likely, they're not clozapine related. And that's been my experience as well, especially in the COVID era. It causes neutropenia regularly. And what that does is dangerous because we monitor people and there's mandatory stop points. So if your white count goes below 1,000 and you do not have what we call benign ethnic neutropenia, you're forced to stop clozapine. So you're putting these kids at risk. Intensive monitoring does far more harm than good. Most of these episodes of neutropenia are harmless. It's extraordinarily rare, and it's inappropriate. I'm going to show you more data for that. This is looking at the FDA's own database. This is the Sentinel database, 94 million claims, all events with primary diagnosis of neutropenia. This is the data. If you look especially at the age of 18 to 44, since that's the group we're using clozapine, at least we're initiating clozapine for, you'll see that olanzapine actually has a 7-fold, actually 6-fold risk. Keppra, which is, I won't try to pronounce that, but that's the one with a 29.95 risk. Again, it's highly inappropriate what we're doing with clozapine. It's prejudicial, and it's an obstacle to the use because it's hard to get psychiatrists to write it. When they have to do this, it's a lot of mandatory work, and it is counterproductive. Further evidence, again, life-threatening 51, when is onset 19 or 20. Again, you know, it's a prejudice. And people do live longer with clozapine. As I was told it would kill my son. Well, this is the data, and this is the best data. This is out of our Finnish people because they learned quick, and there are a very high usage. In fact, in the entire planet, we are tied for dead last with Malaysia in clozapine use. In Finland, it's about 30–40%. So if you're on no antipsychotic, your risk at 20 years of succumbing, of dying, is almost 50%. Any other antipsychotics, it's still fairly significant. And again, remember, these are kids that get sick at 19 and 20. So you're losing a quarter of the population. Clozapine, still 16%. I think we can do a lot better with that. And I'll talk to you about that, why that's as high as it is, a little later. Primarily, the risk reduction is in suicide. We return the suicide risk with clozapine back to the general population. Now I want to talk to you about the Team Daniel experience. So this, again, is a slide based on 2022 February. We are now well over 200 patients, but our continuation rate still remains well over 90%. Again, we're not a first episode psychosis clinic. So really, we've only had about 5% of our patients first antipsychotic be clozapine. What we are is a recovery-based clinic that takes care of people that are highly resistant and often supposedly resistant to clozapine. Data at that point was 120 people that were over a year with us. Their average age was 34, so they've been sick for a while, so we wouldn't really expect them to do terribly well. Our youngest at the time was 17. We've now gone down to 13. Our oldest is now 78. Our longest is 33 years, still about 60% with poor insight, or unawareness is actually a better word, of their illness. And so bad that we've had about a dozen kids now on assisted outpatient treatment, Kendra's Law, court-mandated treatment. And then we have hundreds of others that we're involved in the care with, because I do weekly Zoom sessions and I give a little advice, and I always preface it saying you have to go to your treating psychiatrist, but I try to help out and I try to spread the word on how to do this. Not everyone's a success. I wish I could do better. Again, if you refuse treatment, I can't get you engaged, or I'm dealing with other psychiatrists and they change the medicines, I can't control that. We've had 2 deaths. One woman died at 93 after being on clozapine for a very long time, and that had nothing to do with clozapine, and one was an unfortunate suicide. 24 were lost to follow-up, so we had 11% attrition altogether. So how are we different? We use clozapine as soon as we possibly can. And we really believe that everyone has a right to be well. We use a lot of LEAP, Javier Amador's approach: listen, empathize, agree, and partner. But if you can't get through, you gotta have engagement. So we will use court-mandated treatment. And what we don't tolerate is side effects, because in most studies, the discontinuation rate of clozapine is well over 50%. As I said, we have a retention rate of over 90%. And the reason is we deal with the side effects and we do an ultra slow titration. And it allows them to develop tolerance to the medicine. We stress diet and exercise, and our goal always is meaningful recovery. We want them back to the pre-illness baseline of functioning and well-being. It's the target. How do we do that? In addition, we develop a community. We engage them, the patient and the family. You got to get past learned helplessness and hopelessness. Optimism is really the key. Again, why clozapine? Why as early as possible? Well, the longer you wait, the longer the duration of treatment, or psychosis, the harder it is. There's just more damage done to the brain. Dopaminergic dysregulation leads to overpruning, loss of connection to pathways, loss of neuronal tissue. How much of that is reversible? We're going to find out over the next few years. I think it is, but it takes longer and it's more difficult. Why clozapine? Compliance is better. Recovery is better. Suicide is greatly reduced. Aggression, quality of life, substance abuse. A real important factor is substance abuse is reduced. Patients respond better. Unfortunately, this is what we see. If you wait, you're going to lose tissue. An interesting study showed that the number doesn't change. It's loss of the axons and the dendrites and the dendritic spines. And the concept is they can grow back. There's incredible neuroplasticity. We just don't know how long and how completely. But the longer you wait, the harder it is. So how do we define meaningful recovery? Because that's what we're really shooting for. We want these people to have a life of purpose and meaning. And we define it by being in one of these activities out of the house 20 hours a week or more. How do we do? Well, in the literature, it's rated 14% for people with schizophrenia. In New Zealand, where they use a fair amount of schizophrenia, of clozapine, it's 33%. When people came to us, remember we had over half of our people already on clozapine, though not with an adequate response, we were at 26%. After a year, only 1 year, and these numbers are only better now because I've had more and more people go back to work or back to school, it's 73%. We just have to do the statistics again. And I have a statistician, and I just have to sit her down, and we both have to find the time and go through and get more recent slides and more recent data. It's across the entire spectrum, though. So again, where they're more thought disordered and presumably have a more severe illness, it's a little less than 70%, 69%. But as you go into the other spectrums of psychotic disorder, it's 79% in bipolar with psychosis. With the kids who had anosognosia, the total unawareness of the illness requiring court-mandated treatment, we did it even better. We're almost 9 and 10 that are improved and leading lives of meaning. One thing that I've really noticed is all these kids had been in the hospital within about a year before coming to me, 93% to be exact. And if you go back and you look at the history as a revolving door, back and forth, that stops we're down to 15%, and those numbers are even lower now. They don't go back to the hospital. Why? Because they're better. Someone's going to be a fat slug. That's what I was told. That's a quote. Well, historically, they were right, but that's not what we found. We still have some weight gain, but let me go take you through these slides. Where was our weight gain? It was kids that were underweight, actually. They gained 10 pounds on average. Kids were up to obesity BMIs of about 35, which is a little pudgy, lost 13 pounds. But our most severely obese lost on an average 34 pounds. This is also only getting better. And the reason for that is, as I'm sure you're all aware, they're GLP-1 inhibitors, these weekly injectable drugs, the Ozempics. This data was with liraglutide, and I use semaglutide, which is Ozempic. But actually, my favorite and probably has the best data is tirzepatide. But this is nevertheless with Trulicity, and this is something that we see all the time now. That's male, that's female. I couldn't get it done with all my other agents, but once I added that, it was a slam dunk. And this is across our population. And this is, again, we've been using this before you guys heard of these drugs. As soon as they were approved, I was waiting for them. So we've gone from a population of 73% obese to 40%. And it is lower than that. The weight gain or the weight loss is trivial. I mean, not trivial. The weight gain is trivial. The weight loss is dramatic. Substance abuse disorder. I'm really proud of this. 50% we're using. We're down to 8% in our population. Cannabis was the primary drug. There's nothing specific to stop cannabis, but there's something about clozapine that allows these kids to quit. Smoking, probably the one most addictive substance that we have. Well, in healthy people, it's less than 40% that are successful quitting in their first attempts in their first year. 15% with serious mental illness. In our hands, 67%. We're very aggressive. We use all of the medicines, the varenicline, which is Chantix, bupropion, nicotine replacement therapy, and we actively encourage. I'll see them vape. I prefer no nicotine, but I will settle for that. Risk reduction. Okay, whoops. There we are. So it's not all wine and roses. The two things that I fear most with clozapine, and this is why there was that 16% death, is pneumonia and severe constipation, which we'll talk about on the next page. Pneumonia historically has killed 30% of people on clozapine. We've had now over 25 pneumonias. I've been adding them up after this. We've had 0 deaths, and I will tell you why in a little bit. Seizures are a complication. And where's my constipation? Constipation really hasn't been a major complication. It's what I worry about, but I'm so good at treating it, it just hasn't happened. Of the substantial weight gain, 7 wouldn't take the meds, and 3 were new to the weight control regimen. So I'm very curious when we get new data, what our data looks like. What really I also want you to look at is the movement disorders. You'll see that with all the other antipsychotics. It's extremely rare with clozapine. And this is a slide I want to dwell on. Remember, our goal was to return people to their pre-morbid level of functioning. So this is preliminary data only. This is only 14 patients. I'll be honest, we'll come out with it. But it is what is possible. These people started at 80. This is a global assessment of function scoring. If you're 100, you're Barack Obama, maybe Michelle Obama. Again, you're a magnet for people. People love you. They're coming to you. You could do no wrong. You're incredibly bright. 80 is a pretty well-functioning person, may have a little social anxiety, but they're out there doing pretty well. They may have some quirkiness, some issues. When they're untreated, it goes all the way down to 19. These are kids that are routinely hospitalized, suicidal, and violent. when they're given an antipsychotic. They get much better. This is what I call good enough treatment. And this is the typical dopamine 2, the first and second generation antipsychotics. And they improve from a global assessment of function of 19 to 38, which is much better. But where are they? They're still very symptomatic. They still have major cognitive issues. They still have major negative symptoms, and often they still have positive symptoms, and they are restricted. They are socially isolated. They are not working. People that came to us on clozapine were doing better than that. They were at 56, which is starting to go back to school, starting to be involved in social life. By 1 year with us on an optimized regimen, they're back to their baseline. So how do we do it? The first step is really to get to know you and the family, get to know the patient and the family. We don't have a lot of barriers. I really try to befriend people. I am not a psychiatrist. I'm a nephrologist, a gerontologist. I call myself a psychiatric internist. I do not try to do therapy, but I do believe in befriending, and I'm an active cheerleader. I try to listen reflectively. I've taken Javi's course multiple times. I do the best that I can, but I want to engage. I have to engage if we're going to get anywhere. But you also have to make sure they're feel safe and accepted. Also, these diseases are not linear. I wish they were. It doesn't take much to screw things up. I'll screw things up. We all screw things up. You'll screw things up, but I promise not to abandon you. I'm always available. And I think this is part of the thing, because there's going to be a lot of questions. Clozapine is not an easy drug to use. I already showed you it can work, and it works great, but it's not easy. So people have to have contact with their physician, and it has to be readily available. And then the physician has to not be a cold fish. They have to be compassionate. They have to connect. And you have to communicate. Everyone leaves my office with a treatment note. And you have to be optimistic, but you have to be patient and realistic. So we describe our approach, and I didn't put this slide in here because I'm an information technology idiot, and I didn't move it over from my other slide set. We describe our approach called the EASE model for optimum use of clozapine, and that's the article I published with Matri Keshvan and my wife, Dr. Mandel's, in Schizophrenia Research, just November 2023. Basically, EASE is an acronym, meaning the first E is for early treatment. Obvious reasons, because the earlier you treat, the better the results are. We know this. A is for assertive monitoring and assertive management of all side effects. S is for a slow titration, so the patient tolerates the medicine and you can address the side effects. And if they're almost always on another antipsychotic, lead to a slow titration of the other antipsychotic. And then the final E is engagement and community. So as I said, therapeutic drug monitoring is critical. Why? A lot of the kids don't take the meds, first of all. If you don't know what they're taking, it's hard to judge where it is. There is a dose response curve with clozapine. A lot of the sicker individuals need higher levels. It's all about the levels. So you need to do therapeutic monitoring. You need to do the medicine. You want to get your baselines and you want to go from there. And you always want to address substance abuse. Ronald Reagan, I'm a Democrat, but Ronald Reagan said it best: trust but verify. Oops, there we go. And then the avoidable side effects. I'm going to go through this quickly. If you guys are interested, I have a whole nother slide set, and my information will be on at the end, that describes how to go through these things. As I already said, weight gain, if you do it right, is a non-issue. It really is totally treatable using metformin, diet, exercise, and especially these GLP-1 receptor agonists, which are now being studied and seem to be very important neuromodulators and leading to increased neuroplasticity and improvements in especially bipolar illness. There's a gentleman studying this in Toronto. I I'm blocking on his name right now, but Roger McIntyre. So again, the high triglycerides, the weight gain, the metabolic syndrome, it's the same thing. And there is very remediable. The fast heart rate, clozapine, unfortunately, has a bit of an anticholinergic burden. I'll speak English. Basically, it makes your heart go fast. It slows down your digestion. So as it goes up, the levels go up. It's not unusual that your heart will go up. You don't want to tolerate that fast heart rate. That's how you end up getting to the point where some of these people will develop heart failure. You don't want that to happen. The quote-unquote cardiomyopathy or heart failure is secondary to a persistent fast heartbeat. Basically, the heart is a muscle and it gets exhausted. You want to pay attention to seizures. Clozapine lowers the seizure threshold. And again, a lot of these kids need higher levels. Drooling is one of the primary factors, that and sedation at night, that led to Daniel's aspiration pneumonia, and why we have this mortality with clozapine, with the pneumonia. You want to avoid this. So you want to decrease saliva at night. So you can do this by topical agents. There's something called glycopyrrolate. You have to be careful with that because even though it doesn't cross the blood-brain barrier, it is anticholinergic and it will increase your heart rate and it will increase or decrease bowels. But it won't tire you out since it doesn't cross the blood-brain barrier. And a simple thing like elevating the head of the bed is really important. Constipation is the other big side effect. It's almost universal. A lot of the drugs that we use for the weight, though, do help. All the GLP-1s, will help because their side effect is diarrhea. Metformin does as well, but almost everyone needs either a cholase or a cathartic, a laxative, Ducaloxacena. Milk of magnesia is not unreasonable as a per needed basis. I don't like to use a lot of magnesium in the long term. I don't use a lot of lactulose anymore because it's too much gas, but Miralax I love, and it has a great track record and it's safe long term. Finally, there's newer drugs out, but they're expensive, and you can use those as well. What are called secretogs. They actually make you pour out fluid into your gut. But the bottom line is you got to treat it. And you have to pay attention to it. I show most of my patients what's called a Bristol stool chart. I probably don't have one here. Basically, it's a picture of stool. And I didn't bring it home with me. I meant to. So sorry. I'm sure you all would have liked to see the pictures of stool, but you just can't ask them, how is your bowel frequency? They'll all say it's okay. You have to be very specific. And you want to say, is it little balls? Because I can't tell you how many people have had large plumbing bills because the stools will clog up the toilets. Little round balls, that's constipation. Get a Bristol stool chart. Neutropenia, we talked about. It's really not a big deal. But again, there is a surveillance bias, and you will get some low white counts. So what do you do first? Well, neutrophils have what is called a circadian rhythm, a daily rhythm. It's lowest in the morning. The first and easiest thing is just to repeat the blood count in the afternoon. It goes up. The other easy thing to do is because the white cells live on the blood vessel walls and you don't measure them when you routinely draw blood. But when you exercise, those white cells are mobilized into the circulation and you can mobilize and you can measure them. And that will increase your white count by about 50%. Finally, you can use lithium. In my 15 years in tens of thousands of prescriptions now, I've never missed a dosage because of a low white count. A benign ethnic neutropenia in people of color is fairly common, and you have to recognize that. These are people that typically run lower white counts. The interesting thing is their incidence of having a very low white count below 500 is even lower than the general community, which is, as I said, incredibly low to start with. If you don't ask about bedwetting, they won't tell you. You have to ask about it. The remedy is really simple. You start with behaviors, which is don't drink close to bedtime, but you can actually give them a short-acting oral hormone, DDAVP. It's antidiuretic hormone, desmopressin, it's its other name, and that will usually be enough. Myrbetriq is something that works on bladders. You almost never need that. And then when they're going up, clozapine relaxes blood vessels, also easily fixed. All you do is give them something to retain salt and water. They're young, they'll handle it. They've handled it well. In severe cases, you have to give them something that'll make the blood vessels less relaxed, and that's midodrine. Nausea and vomiting is an issue. Again, you're slowing the entire GI tract all the way from the esophagus all the way to the anus. So they can have nausea and vomiting. We use a lot of Zofran, and we use something, ondansetron, and we use a lot of metoclopramide, especially early when it can be a little bit more severe. Do not tolerate it. All right, enhancing clozapine. I want, this is again an old slide. I tend not to use the cognitive enhancers early. That was a mistake I made in the beginning of my practice. I will use these, but you must take care of the positive symptoms first. All of the cognitive enhancers, the donepezil and the mematine, are drugs typically used in senile dementia. They work on important receptor systems that are important for cognition, but eventually they affect dopaminergic transmission. They can worsen psychosis. So you shouldn't be using these until the positive symptoms are better. Bupropion, even famotidine, which increases histamine at very high doses, famotidine, will do that. Modafinil and armodafinil are also dopaminergic, as is amantadine. You can consider fluvoxamine, but again, I don't even use that very early. Wakix, we investigated. I was very unimpressed, and we really found that just using famotidine to increase histamine transmission in the brain was as good and safer. But what you can do is use other therapies, and especially CBT, and use cognitive enhancement programs. As they get better, they're going to be able to get into this. You have to get them to the point where they are able to participate. So none of this is early, but these are important things. I'm fond of saying the medication doesn't make you better by itself, but it allows you to do the work to make yourself better. So it's really important to get them into these therapies. And then you always have to treat co-occurring conditions. Now, I would never have shown you this slide early, because first you would shut me off right there. But this is what it is. We average 11 different medications along with what we do, with all the cognitive enhancement treatments, with all the therapy. It is a lot of work. But as I think I demonstrated to you guys, it's worth it, because these kids really look good. You would never know the vast majority of my kids have, quote unquote, anything wrong with them. They are living in society. I have a college professor. I have people that are psychiatric social workers. I have married people. I've gone to a few weddings. This is not what I was told happens with people with schizophrenia. It doesn't have to be what you guys have been told as well, but it is a lot of work. You can see what I use. I use clozapine, laxatives, colace, metformin. We use a lot of fluvoxamine. We're going to get to that eventually. I am very aggressive. The GLP-1s, again, this is an old slide. I'm much higher. Sodium glucose transport inhibitors, it makes you pee out a little sugar. It's a good thing to have. Some of these people are on lithium. We use a little of all the others. But what we don't use is we never use direct dopaminergic stimulants. We don't use the stimulants at all. Again, it increases the risk of psychosis. There's dopamine dysregulation, and it's right around the corner. Why would you ever do that? We rarely use Depakote. I know that if you look at the Clozapine handbook, that is the drug that Jonathan Meyer recommends for seizure. The problem with that is it causes sedation, and if you're on it at the beginning, it increases the risk of myocarditis and agranulocytosis, again, the low white count. It's associated with hyperammonemia, weight gain. It's not a good drug to be used with clozapine. We already have enough anticholinergic with the clozapine itself. So I stay away from the benztropine because that gets through the blood-brain barrier and will sedate you and affect cognition. And hydroxyzin, I've seen a lot of people use for as needed for agitation. We can do better than that. I will use a beta blocker plus clozapine at low doses. 10 of propranolol, 12.5 or 25 milligrams of clozapine works very well. And when I really am in a pinch and I need to get things under control, I will use a benzodiazepine, but I use benzodiazepines only as needed, except for in the setting of catatonia, where you do need to use it. There we go. Now, one thing I really emphasize is, again, exercise. And what we used to do before COVID is our families would come to our house every Saturday. And really, this was part of the secret sauce. You treat people like people. You normalize. It's out of the medical environment. People relax. It was an incredible thing. Then COVID came and we went to straight Zoom, and now we do a hybrid. Because once we went to straight Zoom, our reach expanded across the world. Literally across the world. We have people in South Africa, France, England, Venezuela, Mexico, Canada that join us on our Zooms on Saturday. So we go back and forth. My house and Zoom, but it's engagement. What are the benefits of exercise? Every study that's been looked at, pretty much, it's the magic bullet, which means something that you don't have any downside risk to. It improves all symptom scores. Again, exercise, brain, exercise, body. It improves your quality of life and your functioning. This is an example of our teamwork. I'm a marathon runner. Philadelphia this Sunday will be my 112th marathon. I'm going to be running it with the two boys on the side. Michael Orth, who's our commissioner of mental health up at Westchester's, run several Bostons with me. And this was Long Island Marathon. And the boys to the side, I'm 66 now. It's gotten too fast for me. So this is the first time I'm not starting out with them. They are going quick. The littler of the two just ran a 3:13 marathon. The taller of the two, I expect them both to be in the 3:20s. They're planning to stick together. We'll see how they do, but I expect they'll do very well. How many people you see with schizophrenia that run marathons? Anything is possible with clozapine. Diet, we emphasize. Again, they can participate. Again, we say, don't drink your calories. And it's basically a Mediterranean diet. Stop the simple carbs. Again, the ease, slow titration. Take your time. Clozapine is considered to be a lifelong medicine in the vast majority of these people. Clozapine's good effects go away if you stop the medicine. When stopped and looked at and to see what's the next medicine that people will use, the next medicine was clozapine. We use clozapine. We usually split the dose in the beginning because you usually will need a split dose for positive symptoms. This is just, I want you to have this slide. This is an initiation slide. This is a maintenance slide. This you can share with your doctors. That's all that it's there for. Again, slow titration, minimize side effects. The incidence of cardiomyopathy and myocarditis goes to almost nothing. I gave a talk in Sydney, Australia. Their incidence is 3%, but they go way too fast. Hopefully they're going to change. This is the standard titration in the PDR. Way too fast. We are literally 1/10 the speed, and that's why you need patience. But again, it's a lifelong medicine. If you do it right, you save your kid's life. Total daily dose. It's very different where you are on the spectrum. 100 milligrams versus 325. And we're low because, I'm finally getting to that fluvoxamine story, because we use a lot of fluvoxamine and that pushes the levels up. If you see here, we have a full quarter of our population in what would be considered the toxic zone. It is not toxic. It is the levels that these kids need. Very brief primer here. The message here is cigarettes will lower your clozapine levels. You have to be aware of it. It takes very few cigarettes. Caffeine increases it a bit. Keep your coffee steady. Be aware of drug interactions. Cipro is the real notorious one. It'll raise your levels for flow. Also, Paxlovid, ritonavir, you can't take it with clozapine. It triples your levels. The other thing, remember I mentioned the pneumonia being such a big risk factor for death with clozapine and why we never get, no one has died ever in the 15 years, even though we've had over 25 pneumonias. The reason is we are aware that if you do get a serious illness, this pathway slows down. And if a pathway that metabolizes a drug slows down, what that means is the drug accumulates. And you can see an accumulation of drug that's threefold. You'll get a clozapine intoxication unless you respond. So people with severe infections, especially lower respiratory, pneumonias, bad COVID, we tell people initially to cut their dose when they're still having fever by 50% immediately. And all my patients know this. And that has happened multiple times. In the COVID era, 0 deaths. There's a reason for it. And if they're still sedated the next day, we will go down to a third and we get a new level to see where we're at. Therapeutic drug monitoring is critical. Finally, fluvoxamine. Why I use fluvoxamine. Again, we had a very resistant population. We had people age 34. That's why my levels are so high. I need to use higher levels. How could I do it? I thought, well, I know clozapine and norclozapine both contribute to side effects pretty equally at that. But clozapine is the only agent, as clozapine gets broken down. Once you break down clozapine, the other agents are not effective antipsychotics. So I decided to use the CYP1A2 pathway and block it, increasing the clozapine to the norclozapine. So I got rid of the ineffective drug that had equal side effects and was able to raise the clozapine level. And what that has done is given me a better medication. Having said that, you can't do this lightly. You can cause seizures. It has to be done extremely carefully with careful monitoring. 6.25, which is a quarter of a pill of the lowest dose, can raise the doses by 20%. What's the model? Well, what we have done so far is we kind of created this. We have us, which are internists. We do have a psychiatric social worker doing therapy for us. We have peer specialists who are on clozapine because it never hurts. In fact, it's tremendous aid to have that, to show what people can look like. It reassures family. It also, Daniel comes by and talks to people and has been a real instrument in this. He does a Zoom session after my Zoom session with the kids. And we really work at creating that community. We befriend, we normalize. Exercise, CET, cognitive enhancement training, CBT. We do all these things. We work on substance abuse. Dogs do matter. I'm a big dog lover. You stare into a dog's eyes, you get oxytocin. That's another thing we've started to use. It's a bonding hormone. It helps with social anxiety. But the goal is meaningful recovery. One more thing. Remember I told you about the blood draw every week? Well, that's changed. You can now do a finger stick. There's a device called the Atlas device. So instead of having your son or daughter go off and get their bloods done, you can do this at home. The contact is ggprx.com. That's goldengatepharmacy.com, ggprx.com. That's where you can come up with the Atlas device, and they will run you through your insurance and they will work with you. It is very useful to have, and we recommend that people have it at home. Just makes it much easier, not having to go out and get your blood drawn all the time. That's our Zoom session. I just want to show you the few people. The top person on the left is the one who usually runs the session. That's my lovely wife. I'm a lucky man. That's Dr. Ann Mandel, also expert at clozapine management. Angela Brisbane is one of the many people that help run the Facebook page. Bill and his lovely wife, Nyman, is helping me rewrite my book right now and is much better writer than I am, so I'm hoping the language will be much better. Rachel Strife runs the Zoom when I'm having people over to the house. And Karen, off to the left, helped us with the writing of the book. And then the rest are other people that agreed to be on the picture. What do people say? It gives them their kids back. And people on clozapine, it quieted my mind instead of deadening it. We're good. Picture's worth 1,000 words, and we're ending. This is a kid who's an really great artist. You can see this is before illness. This was on olanzapine. A little detached from reality. I'm not sure what the middle picture is, and that's some form of fruit off to the right. This is on clozapine, still subtherapeutic. And this is characteristic, of what happens. They return to reality. So these are the realities. We can do a heck of a lot better. We just need the will. It's a brain disease. I hope I've convinced you of that. It's really common. Cognition has to be addressed. It's really costly and it's chronic. You're going to need to stay on clozapine for your life if you have psychotic disorder. There could be something coming down the line, but it's been almost 70 years now, and nothing has come down past it. It's lifelong. It's crippling, and it's neurocircuitry. What is my dream? I dream that I get the best delivery system for clozapine. My dream is that we take the intramuscular formulation, which is available in Europe, but not in the United States, and we make it a weekly long-acting drug. My dream is that people come into the office, they'll get their GLP-1 injection and their clozapine injection. Because again, what's the toughest part? Is getting the people to take their medicine. Again, if they're unaware of the illness, that's why the only setting where you really can't use clozapine in this time is when you can't get engagement and you can't get them to do it. You need engagement. Two important references, very self-serving on my part. Just a lot of my other references. I just want you to have the slides, and that's the connection. And I'm ready for questions. I told you I had 70 minutes.
Thank you, Dr. Laitman. So we do have a few questions and comments in the chat. The first one, can you discuss the relationship between schizophrenia and comorbid disorders?
Schizophrenia and comorbid disorder. Well, we know when people come to us, they already tend to be overweight. So there's a higher incidence of diabetes. Certainly, we also know that it's a neurodevelopmental disorder, so that kids with autism, a full 20% of the autism spectrum illness kids will go on to develop a psychotic disorder, and there's a male predominance in that. The co-occurring conditions, it's interesting. Remember when I was talking about the neurobiology and I was talking about attention deficit disorder and talking about immaturity? Well, that's more a reflection of the negative symptoms. They're not true comorbid conditions. They're part of the psychotic disorder, and they're just missed opportunities. And I want to make the point, we now know there's some wonderful work being done with cognitive enhancement treatment with kids that are considered high risk for psychosis. So you can head this off before it develops a full-fledged psychotic disorder. Work done mostly by McGorry in Australia. He is the king of the high risk and early treatment. So he has things called headspaces, and he has gone through the school system. In fact, McGorry was Man of the Year in Australia. Something I will never be in the United States, but it's nice to know that someone got that attention for taking care of psychotic disorders. And what they did is they went through classes and they identified high-risk individuals. So normally a high-risk individual, about a third will go on, live a perfectly normal life. A third will go on to develop not full psychotic disorder, but will be quirky, almost schizoid, but will have some form of life. And a third go on to schizophrenia or a full-fledged psychotic disorder. Again, they're not comorbid. It's part of the development. With McGorry's hands, he's shifted that ratio. Still some go on, but less. And the thought is that you're increasing processing speed. If you increase processing speed, that helps you with social interaction. That dramatically decreases the stress. If you're decreasing the stress, you're decreasing dopaminergic dysregulation. And it's kind of a circus rhythm. If you're cutting that off and you're allowing neurodevelopment to go on. Dopamine is also poison for your brain. It over prunes. So why these kids really start to get sick at age 13 is because that's the time when you have the most synapses. That's when your brain has twice the number of synapses, which is the active component where you make your communication between each neuron in your brain as compared to an adult brain. At 13, you start normal synaptic pruning. So good pathways are strengthened. Pathways you don't use get pruned. With psychotic disorders, there's an overpruning. When there's dopamine excess, there's a dramatic overpruning. So these kids that have the attention deficit, low process speed, really can't socially interact, are also starting to socially isolate, and you need that for you to develop good pathways. That's why you start to develop a full-fledged psychotic disorder in your teens and the early 20s. I hope that answered your question.
I hope so. The next one is, are there any preventative measures for schizophrenia, like diet or exercise?
Well, that's what I was saying. Yes, we're thinking there are. Anything that's going to change the formula, anything that's going to engage your brain. So again, cognitive enhancement treatment, working specifically at these games, these silly little games, Lumosity.com, BrainHQ.com. We have, and I'm sure she won't mind, we have tied in with a place called Laurel House, and there's a program called Thinking Well. And this was something developed from the Lieber Institute, from Alice Medalia's work at Columbia. She set this up. And basically, she uses those two modalities, and it's with social interactions and working at this. So yes, something could have been done. And exercise, yes, if you could start them exercising, that's incredibly important. I failed to mention that with my own history, I was a straight A student in high school, top of everything, until my junior year, when I suddenly became a straight C student. Stayed home, started to isolate, missed 60 days of school, would rub the thermometer. My father's a clinical psychologist, he missed it. I had a good cognitive reserve, so I could fake it pretty well. That after junior year, I got lucky. I made a decision that I didn't want to be depressed, or so I thought. In full retrospect, it was probably the depressive phase of my bipolar illness, which I got lucky. So what did I start to do? My father was a jogger. I started to run. And that's how I've gone through 112 marathons, 50 to 60 miles a week, which I've kept up to this day. I've never been depressed since. And I've maintained a state of hypomania. So yes, exercise on a very personal level can be important. But you get them into therapy, you do the befriending, you start to challenge some of their psychotic thoughts early on before the full-fledged illnesses. The problem is recognition. And then there's things you need to avoid. You need to avoid pot. My sister and I both tried it. I got paranoid. My sister got paranoid. We both thought it was bad pot. Tried it again. Both got paranoid. Stopped. My brother, the straight arrow, never tried it, thank God. I am susceptible. I have a very high genetic score. ADHD drugs. If you have it in your population, your kids are at risk. It's dopamine. Why would you ever give excessive dopamine to a system that's already revved up and is stressed and has dopamine excess? It doesn't make sense. So avoidance, exercise, therapy, it's the best that we have right now. Is there a medicine that will change it? No, not at this point. People are contemplating using tiny doses of clozapine since it has effects on the neurotransmission. It seems to decrease the microglia. I'm sorry, I'll speak English. That pruning I was talking about, the immune cells in your brain do that. The only drug that affects that over pruning, because it dampens down the immune cells in your brain, is clozapine. So some people have entertained the possibility of very low doses of clozapine early in the illness to avoid the over pruning. But we know things that fire together, or excuse me, fire together, wire together. So an enriched environment, exercise, that's where you start. And yes, a good diet. Palmer, very interesting fellow. It's not that easy. I wish it was. If you ate right, the biome is important. Yes, and I recommend eating a healthy diet, a Mediterranean diet. The crap we eat is not good for you. I assure you of that. We need to do better with our diets.
Thank you. Another question is,
I wanted to give you that contact.
Yes.
Denise Vestuti, I got sidetracked. Sorry. Denise Vestuti is the head of the program at Laurel House, and her phone number, I'll read it slowly, is 203-487-1633. This is it's an experimental program, so I'm not going to tell you. Mostly it's my patients right now. We've done about 100 of so of my kids, and there is a waiting list right now because it is an online program. It's only been done in person before, but going at 6 months to a year out now, we're seeing some very positive results. And her email is dvestuti, VESTUTI at Laurel House, LAUREL house.net. I'm back.
Thank you. The next question is, do you think there's pressure on clinics to prescribe higher priced, newer antipsychotics?
It's not pressure, it's just easier. And there's also a tremendous nihilism. Most psychiatrists, and this was really shocking to me, and I shouldn't have been shocked. I remember maybe 5 years into the illness, Daniel and I, because remember we'd gone up to Harvard and met one of the head psychiatrists up there. He wanted to introduce us to his young psychiatrist, his training psychiatrist. So Daniel had done a film and did a stand-up for him. And when we were done and we talked and chatted about how important clozapine is, they came out saying, that was the best experience we've ever had in our psychiatric residency. We didn't know people could be this well. So and this is Harvard, there's a tremendous nihilism. People don't understand how well people can be. So they do the easy stuff, good enough care. You saw these regimens are not easy with clozapine. It is a tremendous amount of work. The reimbursement is not great. I've had to drop out of health insurance, and I was originally part of a single payer system. I was working up until this point, and I have to do labs when I'm done now. So it's just easier. And yes, the big pharmas are in there. And again, if you can't engage someone, I agree. They need to start with something. You have to use it long-acting injectable. You can't use clozapine. The worst thing you can do is start someone on clozapine and have them come on and off, on and off. That accelerates the stress, and that makes the whole process worse. So you need that engagement. Having said that, with Jay Carruthers and Lloyd Cetera over the last 15 years in Office of Mental Health sites, the use of clozapine has gone up from 2.8% to over 20%. So you can increase it if you really put the work in.
Oh, hi, Dr. Laitman. I'm sorry I was on mute. How can people get in touch with you if they have further questions?
You took down my slide. Sure. You stopped me sharing.
Sorry about that.
That's okay. That's why I left that slide up there. But yeah, you have to come
Put
up
it
and
in the
you're
chat.
lovely, much better looking than me, and I'm almost dark here. Try to get
Thank
the
you.
light right.
Well, we'll put it in the
But
chat.
yeah, put it in the chat. So it's R.S. Laitman,
Uh-huh.
Robert Stephen Laitman, Laitman at, because I'm old, AOL.com. And you can call me. I don't answer phone calls usually, but I get texts because I'm busy, and I like to screen my calls because I do get a lot of calls. I apologize for that. But my number is, and I give it to all my patients as well, as 914-629-5130. Just be patient with me. I will get back to you, but I try to answer as many questions as I can. And the point is, it's a lot of work. But the point I'm really trying to make is if you can find someone that will work with you, and this is why I give half my presentations to groups like NAMI, but I give my other half to first episode psychosis clinics, residency programs. Yet I need other people to do this. Unfortunately, I am not taking any new patients because I'm over 200 patients, which is probably about 100% above my capacity. But I'm managing with that. I do consults, but it's, and then the idea there is to engage your treating psychiatrist, show them what can be done, and assist them. So I have other people in the community that are willing to do it. But yes, that's my
Thank you so much. Yes, I am going to put the contact information in the chat. I also did add the evaluation form. So thank you so much, Dr. Laitman, for being here and presenting to us. It has been very informational, and
it was fast. So that's why I'm saying I don't expect you to retain 99% of that information, but it's recorded, right?
It absolutely is recorded. It will be up on our YouTube.
Good. So the one thing is, if you do email me, I will send you the slides, because this was the short set. I have a slide set of over 200 slides that go down the individual side effects, which is what I present to some of the, the programs. And I will send you that. And again, you have to do this with a treating physician or a treating nurse practitioner. But the point is, it's doable. That's what I'm trying to let you know. That after 15 years of this, and this is my last story, let me get this one done. I went to Will Carpenter, who wrote the psychosis section, and I met him at a Brain and Behavior Research Foundation meeting. And I told him Daniel's story, and he said, Daniel's an exception. Do it again. And, he was right. Daniel might have been the exception at the time. Daniel had every advantage. He had 2 doctors as parents. He tested out a very, very high intelligence quotient. He just had the low processing speed. And we had gotten him on clozapine relatively early. So he was reasonable to be skeptical. But we're now 15 years into this. And Daniel, though he was my N of 1, which is a treatment study with 1 individual, he was not the exception. He's the rule. We have over 90% respond, not to get to meaningful recovery, but respond better than what they were on before. Again, I wish it was 100. I don't think I'll ever quite get there. And that's the other thing. Don't give up, even if it's clozapine. You need to push levels, but there are adjunctive medicines. I just didn't want to I got so much in the weeds, but there's other great modalities out there, and there's new stuff coming down the pike. The neuromodulations are really important. ECT is really important. A new protocol called SAINT with transcranial magnetic stimulation may offer a lot of hope for us. And these are adjunctive therapies. But again, we have a lot of good stuff out there. We just have to bring what they've done the research on and bring it to the public. We can do so much better. That's what I think I've shown you. I hope I have, at least.
Yes, thank you so much. So in closing, I just want to say that people from almost all 50 states, DC, Puerto Rico, and 36 countries have joined these public education events since 2020. So please always feel free to invite a friend, and know that our helpline and all virtual programs are available to New Yorkers and beyond. If you have any questions, please call us at 684-3264, or our email is helpline@NAMI-NYC.org. Your feedback is very important to us. And
Nope, you're muted.
oh, sorry.
I unmuted you. Gotcha.
Thank you. I appreciate that. Your feedback is very important to us and helps inform future events. So please take a few moments to fill out our survey. I'm putting it in the chat again. And thank you everyone for your time. Have a great night. And as I mentioned, the presentation will be on YouTube, on our YouTube page.
And thank you, Barbara. And thank you everyone else for listening. I know it was fast and there was a lot of information.
Yes, it was wonderful. Thank you so much for being here and for presenting to us.
It was my pleasure.
Thank you. Have a great night.
Good night, everyone.
Good night.
Right, 7:30, perfect.